Started.
Okay, we'll start the session in the name of Allah subhanahu wa ta'ala, the most merciful and most compassionate. My name is Zaida. I'm one of the trustees with Safina Muslim Cancer Support Network. Before we formally open the event, inshallah, I want to just deal with some housekeeping. If we can go on to the next slide, Nadia. So we will be recording this session and it will be uploaded on Safina Muslim Cancer Support Network YouTube channel for people to download and view. And for those that don't know what our YouTube channel is called, Nadia will share in the chat the details of it so you can access it. Although not many people have got their cameras on, if you are able to put your cameras on, that'd be great. It'll be lovely to see as many of you this evening. If you're not speaking, please do keep your cameras and keep your sound on mute. There will be plenty of opportunity at the end for any Q&As, so please do utilize the chat box for any questions that you have, or equally feel free to come on towards the end to ask those questions as well. I'm sure you're all going to be very respectful of diversity of thought and opinion, but please do be mindful of different backgrounds and opinions and just be respectful at all times. Please also be mindful of inclusivity. There may be some attendees who are non-Muslim, so if you are going to be using any Arabic terms, please do translate those as you go on. Nadia will share some commonly used phrases in the chat box so that our non-Muslim attendees understand what those phrases mean. This session is put together for yourselves. It's purely for education and awareness and should not be constituted as anything providing personalised medical advice. Everyone's circumstances are very unique and specific to their own. So today's session is very much educational and awareness. If you need some specific advice, please do get in touch with your medical team. This is a subject that's often not very well spoken about, and as you'll know from the work that we're doing in Safina Muslim Cancer Support Network, we are very much trying to break down stigmas and taboos, and this is one topic where we feel that we also need to address because not enough is said about it in our community. So hopefully today is a starting point for us at Safina to talk about this issue more. And of course, it's going to be one of many sessions that will follow on the topic of menopause, inshallah. So before I formally open the session, I would like to take this opportunity to talk a little bit about Safina Muslim Cancer Support Network. And I do apologise to those people who have joined our previous sessions and have heard me speak about this already. But I'm conscious that we do have some new members join, and I do want to utilise this opportunity to speak a little bit about Safina. So Safina, we launched approximately 3 years. It's going to be 3 years in March, inshallah. And the reason why we launched it was because our collective experiences were that although there was some great work being done by a lot of the mainstream organisations and charities, there was nothing specific out there for Muslims impacted by cancer. And every single one of us that have been involved in setting up Safina has been impacted by cancer, either through a personal diagnosis like myself or a family or a loved one being affected by cancer. So there's a lot of things that we've been doing over the last 3 years, but if I was asked to capture it in sort of bullet points, I will use 3 main headings, which are we provide a befriending support service and a bereavement support service as well. And this is provided by our trained volunteers who have all got lived experience of cancer. And this is provided to people who've been either diagnosed or sometimes often you find that the hidden voices in the cancer journey are family and friends. And we also support them as well in their cancer journey. We also do a lot of work on education and awareness. Research shows time and time again, and our own research also showed that the awareness of cancer within the Muslim community is really low. In fact, I think our research shows that over 80% of people did not know in our community what the common signs and symptoms are for the top 5 cancers. So my colleague Safia and her team are doing a lot of work trying to educate and raise awareness of cancer within the Muslim community, and also to break down those taboos and stigmas that exist around cancer within our community, similar to what I mentioned earlier about menopause and stigma and taboo as well. And the third thing that we are trying to do is we are trying to address some of the inequalities that exist within the healthcare sector when it comes to people from our community. And again, research shows time and time again, for example, there was some research done that showed that people from the BAME communities and background, which would also include Muslims, on average are waiting 6 weeks before they get their diagnosis, and that can make a difference between, you know, life and death and the prospects of the success of treatment and prognosis and outcomes. And at Safina, we really want to change the narrative of that, so we are working to address those. That's essentially a quick sort of whistle tour of what we are trying to do. There's so much more that we are doing as well, but underpinning everything that we do is our faith and culture. And you'll see from our website, there's so many resources that we've got, which is sort of faith related on cancer and illnesses. And recently we've also launched a Q&A service on our website, and this is a free service that anyone can use who has got a question on any medical condition. It doesn't have to be cancer, but from a faith perspective, and one of our scholars will answer that for you. And we've currently got 4 male scholars and 4 female scholars on board, so inshallah they'll be able to answer those questions. We're also recently launching our second book. Our first book was Mama's Cancer Journey, which was a children's book that parents can use to explain a cancer diagnosis from a faith and cultural perspective. And we have gone to print on our second book, which is a cookbook based on prophetic foods, sunnah foods, and that should also be, although that's currently available online on our website, but once it comes from print, that will be available for free for anybody who wants a copy, inshallah. So today we're talking about menopause, and I think this is a really important topic, and I don't think it's a topic that we talk enough about within our communities. And I came across some research by Balance that said that 80% of women said that they never discussed menopause at home while growing up, and I think the figures probably are going to be higher for our community, sadly. And this suggests a generational, familial silence on topics such as menopause. And I think it's really, really important that we have those conversations, not just with women from our communities, but also men as well, so that they know what the impact of menopause can be as well. So just before I want to introduce our speakers, I just wanted to mention that although we are a faith-specific organisation, so we are set up to serve the Muslim community, our doors are in fact open to everybody. So if anybody wanted to come to us, whether it's Muslim, non-Muslim, faith, no faith, we would never turn anybody away. And I just wanted to make that clear. On that note, I'm really pleased to introduce 2 of lovely speakers this evening. First is Dr. Farah Ahmed, who is a GP and who specialises in women and health menopause, and also Dr. Farah Uddin, who is a BMS accredited menopause specialist and GP and founder of Liberty Health Clinic. Really pleased to have you both here. Assalamu alaikum, and I'm going to pass over to Sister Farah first.
Hi, assalamu alaikum, and hello everyone. Good evening. Thank you for joining. Just a little bit about myself. As I have mentioned, I've been an NHS GP for the past 15 years, and I now solely work in the women's health and menopause space. I'm also an advisory board member to a couple of charities, especially those that focused on marginalised groups. Written a book on PMS and done some publishing as well. And it's always great to be involved with platforms such as Sabina, just to really help empower you with all the knowledge that you can, just to make decisions, informed decisions about the future of your health. I'm going to hand you over to Dr. Farhat, and she will introduce herself.
Assalamu alaikum everyone, thank you for joining us this evening. As Farah said, I'm Dr. Farhat. I'm a GP with a special interest in menopause and women's health. Similar to Farah, we've been around for more than 15 years doing what we do. About 4 years ago, after I did my British Menopause Society advanced training, I set up Liberty Health, which is a private women's health platform. I'm really passionate about this subject, attend lots of conferences and speaker events to try and educate women, and especially passionate about spreading awareness in the BAME community. I'm also an NHS GP. I work in Putney in South London. I'm going to hand back to Farah now.
Right, so let's dive in. So we'll start off with talking about, or explaining what perimenopause and menopause is. I feel these terms are everywhere I look, on WhatsApp groups, in conversations I'm having with my female friends, in conversations I'm having at work and outside of work as well, TikTok, social media, you name it. So it's just wanted to get some clarity over what those terms mean, why they're important, how we diagnose perimenopause and menopause, and then, more importantly, how to manage symptoms. We'll touch a little bit on HRT, and then understanding menopause management after cancer will be led by Dr. Farhat. Next slide, please. Right, so if, like me, you're a woman in your mid-40s and you grew up in the 90s on a diet of Bollywood movies, these women will need no introduction, but just for the sake of clarity, on the left of our screen we have Madhuri, just living her best life, and on the right we have a Bollywood actress called Kajol, who seems like she actually needs a bit of a lie down and maybe a spa weekend. But the point of this is, and joking aside, is that every woman's experience of perimenopause and menopause is hers and hers alone. It's very different to how your sister may experience it, how your best friend may experience it. For some women, if we take Madhuri's example, for instance, can be quite liberating. Finally, end of periods, not having to worry about contraception, not having to worry about planning your life around your cycles, being able to partake in spiritual activities, in things like prayer, Ramadan, fully, not worrying about contraception or investing in period products. But for others, like if we look at Kajol, it can be the quite opposite. It can be associated with low mood, with anxiety, with despair, often marks the end of your fertility journey. And also for some women, having periods, it's tied in quite innately with the sense of femininity as well. So just in a nutshell, every woman's experience is different. And I know it's easy to compare, but try not to do that. Next slide, please. So stages of a woman's life. So if we look to the left of the screen, so that's from the mid-20s into your early 30s, we get nice regular periods, no menopausal symptoms at all, and that's kind of your reproductive age. And then from mid-30s onwards, things start to go a bit funny. So your ovaries produce two hormones, estrogen and progesterone, and normally you get these nice fluctuations in the hormones, and they're kind of talking to each other, they're best friends, they're working in sync. But from mid-30s onwards, they've kind of fallen out, and estrogen's doing her own thing, progesterone's doing her own thing. And not only are they not working together, but they're gradually declining. And that kind of manifests in your perimenopausal symptoms. So things like irregular periods, we hear a lot about hot flushes and night sweats, mood disturbance, vaginal dryness, lack of libido, sleep issues, weight changes, dry skin, and all sorts of weird and wonderful symptoms. And depending on what quotes you take, it's estimated there are up to 96 different symptoms that could be attributed to the perimenopause. Then we move on to menopause, which is actually a one-day event. And it's a bit of a funny one because it's a diagnosis we make looking backwards. So the clinical definition of menopause is 12 months after your final period. But of course, nobody knows when the next period is, whether it's going to be the last one. So once you've had your period and then you've had no bleeding for a further 12 months, you are deemed menopausal. And that's, like I said, defined by no bleeding for 12 months, but also those perimenopausal symptoms may still continue into the postmenopausal life. And that's when your estrogen and progesterone levels, not quite zero, but very, very low, and they just continue on a very low basal trajectory. Next slide, please. So again, I love showing this graph to all the ladies that I see in my clinic. So what I think the whole purpose of this graph is to validate them. So during your reproductive years, so from up until about your late 30s, you can see that estrogen and progesterone, if you look to the right of the screen, nice and rhythmic, very stable, seem to be behaving themselves. But then if we shift to the pink bar, where everything is a bit haywire. So what I'm trying to show women is everything that you're feeling, so the new onset anxiety, the low mood, the inability to function in the way that you open the fridge and you find your car keys, that sort of thing, the dry skin, loss of libido, palpitations, all sorts of things. It's not you're not imagining it, it's not in your head, it's very much your hormones. And then if we shift to the right of the screen, we can see again postmenopause, those hormones decline quite sharply. Next slide, please. So in terms of managing symptoms, you can see I'm a bit of a Bollywood fan. I've got Rani Mukherjee looking very upset there. So mood things are quite significant. So anything low mood up and down, new onset anxiety, irritability, loss of confidence, low self-esteem. Something I hear a lot of women say is, I just don't recognise myself. That's probably the number one. I'm sure, Farah, you can agree as well. That's one thing that we hear time and time again. In addition, there's vasomotor symptoms. That's a fancy way of saying hot flushes and night sweats. And although these are symptoms, the vasomotor symptoms are something that's often quoted in a lot of literature, wherever you read something about perimenopause or menopause, they talk about hot flushes and night sweats. The reality is, in my day-to-day clinics, I seldom have women complaining of these. And we know that these are heightened in women from the Black community and less so in Pakistani and Indian women. Why? I don't know, maybe genetic predisposition, who knows? But South Asian women in particular tend to present with non-specific vague symptoms. So like I said, so low level anxiety, low mood, bit of fatigue, tiredness, and just a bit of no kind of get up and go. Also sleep disturbances as well, so insomnia, disturbed sleep. But the other important thing I need to mention is genitourinary symptoms. So that's a really fancy way of saying urinary issues where you've got some vaginal dryness, you're suddenly getting up at night to pass urine, and that could be 1, 2, 3 times a night. And if you can think about if you're waking up every 2-3 hours, the knock-on effect that has on your mood in the morning, your energy levels, your libido, your relationships, all sorts of things have such a ripple effect. Headaches, joint aches and pains, and a lot of women make the mistake of just accepting that this is just a consequence of aging, but it's not. It's often because they're perimenopausal or menopausal, and there's lots that we can do to help remedy these symptoms. Next slide, please. So why is understanding menopause important? Well, in the UK, the average life expectancy of women now is just shy of 83 years, about 82.9, which I say 83. And if you assume the average age of menopause for a white woman is 51, but for South Asian women, it's about 46, 47. But either way, women are now outliving men. They're living longer, so they have a longer lifespan, but a shorter health span. So though they're living longer, they're spending more of those years in poor health. And that's potentially 3.5 decades that they're spending without their hormones, and the knock-on effect that that has on their overall health is huge, which is why understanding menopause is incredibly important. It also impacts your long-term health as well. It can lead to bone thinning, which predisposes to fractures, osteoporosis. And the reason that's important is because 50% of women by the time they're 80 are at risk of a fracture. And we don't often think of fractures as something that's lethal, but it can literally kill women. So for that reason alone, just make sure we are really paying attention to your bone health, but also your pelvic health as well. It can affect the support structures. It can cause things like prolapse, urinary symptoms, which, although a lot of women can manage, you shouldn't have to manage, because there's a lot of things that you can do, and it really does alter the quality of your life for all the wrong reasons. So if any of those symptoms are present, please go and see your GP or ask for a referral to a women's health hub if there's one available. And women like myself and Dr. Ferret will be happy to help you. Next slide, please. So I talked about the symptoms just now, and there's a list as long as my arm about symptoms that could be attributed to perimenopause and menopause. But there's also long-term consequences of not having your estrogen and your progesterone hormones, and that is heart health is affected as you enter postmenopause, as is your risk of osteoporosis, as I mentioned, vaginal urinary issues, and also some studies, a bit patchy, but can also suggest that it leads to reduced cognition, reduced brain function, memory impairment. Like I said, the evidence is patchy, but we are seeing a lot of women report cognitive and memory issues. Next slide, please. So where to find resources? So lots of self-styled menopause gurus that don't often have many credentials, but what I would say is just go to reputable resources. So one of those is the Women's Health Concern website, and that's affiliated with the British Menopause Society, and this is the patient arm. That's a great website, as is Rock My Menopause. I did some work with them over the summer, developing culturally competent menopause care. Menopause Matters, and specific for this webinar, Menopause and Cancer is a brilliant organisation as well. I know Farah's done some work with them, and I'll let her expand on that when it's her turn to talk.
We've I think we might have a volunteer from Menopause and Cancer on with us tonight, Neva. So hopefully Neva can shed some light on what menopause and cancer do at the end.
Thank you, Neva. Right, next slide, please. So this is an article I wrote with Rock My Menopause. Rock My Menopause are one of the approved patient resources by NICE, the National Institute for Clinical and Healthcare Excellence. I think we've got a majority South Asian audience here, but they also have resources for the Black community as well, all about understanding menopause and all the cultural nuances that go hand in hand with that for South Asian women. Next slide, please. And this is a brilliant menopause and cancer, which Neva will talk a little bit more about later, but it's a brilliant website. It's run by an amazing lady called Danny Binnington, who breast cancer for her that she was diagnosed with. Yeah, and she kind of talks about her experience of going through surgical menopause as a result of her cancer diagnosis and what that means, and that inspired her to set up this great organisation, which is brilliant. Next slide, please. So how do we manage it? Well, multi-pronged approach, lots and lots of things that we kind of have to think about. So first thing is managing risk factors. So things like the cardiovascular health, cognitive health, osteoporosis, and I'll talk about that in a bit more detail. Reducing cancer risk as well. So please engage in the cancer screening program. So when you're invited for your mammograms, your smear tests, invited to submit stool samples, please don't delay that and make that an absolute priority. We know that, as Zahida said, early detection can really alter the trajectory of your future. So please don't ignore that. The role of HRT as well, but also non-hormonal and alternative solutions as well, which Ferret will talk about a little bit later. And most importantly, the role of male allies. We kind of think of menopause as a women's problem, but it's not. It has such a ripple effect into the our wider circle as well. I mean, I live with 4 men, my husband and 3 sons, and they know all about hormones, because essentially if I'm not well, they need to know about it and how to manage it. So we really need to get them involved in conversations, take them along to your consultations, get them to accompany you to webinars like this. The more knowledge they have, the better place they are to support you. Next slide, please. So general advice, and this is something we all know anyway, but I'm just going to reiterate it. So NHS recommends 150 minutes of physical activity every week. I know how hard it is to carve out 30 minutes 5 times a week. So one thing I say to my patients is, I don't expect you to start training for a marathon or anything like that. You probably do enough cardio from your day-to-day running around, but what you really should emphasize on, if you've only got time to do one thing, is please start lifting heavy things. It doesn't need to be a case of investing in kettlebells or dumbbells or expensive gym equipment. Just lifting things around the kitchen, around the house. For me, it's my 5 road, but whatever it is to really help strengthen your bones, strengthen your muscles, and protect from bone degradation. And resistance training is another one. So you can get those resistance bands, I think £8 from Amazon, but really use those. And they can be used anywhere. You can use them at home, in the garden, in the garage, whatever. Things like yoga, Pilates is great for your core strength as well. Do follow a gut-friendly diet. Again, as South Asians, I think we're pretty good at cooking from scratch, but with the demands of modern life, that's not always feasible. But the freezer is my best friend. But just try and load up your plate with as much fresh fruit and vegetables as possible, lentils, nuts, seeds. You probably know all this already, but just try. A simple rule of thumb that I tell my patients is just try and avoid anything that comes out of a packet, apart from frozen vegetables. Anything like biscuits, sweets, chocolate, cakes, crisps, just in the bin, don't need them. Optimize calcium and vitamin D, incredibly important, especially for those of us that have pigmented skin. We wear hijab, we cover up, we live in the Northern Hemisphere. We will almost certainly be vitamin D deficient, so just ensure you're taking adequate doses throughout the year and higher doses when the clocks change. Minimize caffeine intake as well, and resort to herbal drinks instead. And as I mentioned, engage in your regular screening checks as much as possible. Self-breast examination, really important. Be breast aware. And what I say to the ladies I see in my clinics, that just examine your breast regularly. When you're in the shower, just get some shower gel and just feel all the way around the breast, even under the nipple, in the armpit, really important. Do that either side, and do that throughout your cycle to begin with, because your breast anatomy will change depending on where you are in your cycle. So then you get to know what's normal for you, because only once you know what's normal, then you'll be better placed to detect what's abnormal. And I would really encourage you to do regular breast checks at least once a month. And if there's any bleeding after the menopause, I did mention that menopause defined as no bleeding for 12 months after your last menstrual period. If there's any bleeding beyond 12 months, please don't think it's just one for the road. It's not. It's never normal and always requires prompt investigation. And finally, contraception. A lot of women have been caught out and kind of think, well, I'm perimenopause, I'm menopause, I'm on HRT, I don't need contraception. But you absolutely do. So for 2 years if you're under 50, and for 1 year if you're over 50. Next slide, please. I'm just going to touch a little bit on HRT, which is association with breast cancer risk. There's a study that was published about 20 plus years ago, 2002, called the Women's Health Initiative study, and that suggested that there was a link between taking HRT and breast cancer. That has since been widely debunked, much like the connection with MMR and autism has been widely debunked, but unfortunately mud sticks, and we're still reaping all the negativities that came out of that. What we do know from studies that have since been completed is if we followed up 1,000 women over the course of 5 years, 23 of them would be diagnosed with breast cancer. Now, for women on HRT, that number would jump from 23 to 27, so an extra 4 cases, which isn't a huge amount in 1,000. But if you look down to the row second from the bottom and see what happens in women who are overweight or obese, your risk of breast cancer doubles simply from carrying extra weight. And yet none of us are telling women who are overweight or obese that you must lose weight, because your risk of breast cancer doubles. So I just thought it's important to point that out for some context. I am now going to hand you over to my esteemed colleague, Dr. Farhat, and she will talk to you a bit more about menopause and cancer.
Thank you so much, Farah. I'm just aware that a few people can't see the presentation. Is that the same for everyone, or is it just a few? Can anyone see the presentation?
Yeah.
Put in the chat if you can see it, or just say yes.
No, we can see it, thank you.
Okay. I wonder if the people that can't see it might benefit from logging in and logging out again, because the rest of us can see it, so you should be able to. Okay, so next slide, please. So that was a fantastic background on menopause, and the symptoms that we all go through perimenopause and menopause vary widely, which is exactly what Farah said, 96 different symptoms that we know about, possibly more. The experience for a woman who's had breast cancer, and I know we're talking about cancer today, but I'm going to specifically talk about breast cancer because it's a very common cancer. We know that it's now 1 in 7 women, so it used to be 1 in 8, but more recently that's we know that's changed to 1 in 7, and that's for a number of reasons, to do with better detection, yes, women living longer, yes, but lifestyle changes. We're more sedentary, we're exposed to more toxins, where we're not exercising as much as we should do. So there's so many different reasons, but this is a group that it is a common cancer, but it's also a very treatable cancer. So women we know that breast cancer isn't one of the highest causes of mortality for women, but it is a very common cancer. And what's more important, or equally important, is quality of life. So it's not just about getting through cancer. And it's, when I speak to women about this topic over and over again, women say to me, they've got through their chemo and they're like, we've done it, that's the worst over. And then I speak to other women, they're like, yeah, I thought that was the worst over, but actually what comes next has actually been harder. And this is what we don't talk about. We talk about cancer, we talk about cure, but do we talk about what comes next after we've cured the cancer? And that's what we want to talk about today, and really shed light on what women go through after they've had their cancer removed and they need to carry on life afterwards. So today I'm going to focus again a little bit about well-being, and we're going to talk about the hormones around this, treatments, and a bit of understanding about recurrence, because this is what we're all worried about. Next slide, please. Okay, so menopause after breast cancer, why does it happen? So menopause can be just completely natural. It may just coincide with the fact that you're going through breast cancer, you're going through treatment, and that could be your time for menopause. But often in these women, it is treatment-induced menopause. So this can be due to chemotherapy. So we know that the toxicity from chemotherapy can affect our ovaries and can lead to an early menopause for women. But ovarian suppression is now part and parcel of breast cancer treatment, especially for estrogen positive breast cancer. So women will often have their ovaries shut down overnight and just go from normal to 0 hormones overnight. And we know that with breast cancer, with treatment for breast cancer, the menopause that these women experience is more intense. It's more intense than the average menopause that women go through, and that is because of this abrupt hormonal change that they go through. Next slide. So women, I won't go into the treatments for breast cancer itself, but they will vary depending on the type of cancer, the grade of cancer, and the surgery will vary from a lumpectomy to a mastectomy depending on where that woman is on that cancer journey. She may have had chemotherapy, she may have had radiotherapy, and it's all personalized to her. And she would have been on this journey and got to the stage where she would have been told, you're in remission. And that is an amazing day to reach, and that's what every woman wants to hear. But it's what happens next, and what happens next is the risk of recurrence that we have to think about. So every woman who's been through breast cancer, their fear is recurrence. And this is what we talk about, and we talk about the endocrine treatments to prevent recurrence. And these include tamoxifen, which actually affects the receptors, so it blocks the receptors, the estrogen receptors. Aromatase inhibitors, things like letrozole, anastrozole, exemestane, which actually prevent the production of estrogen, so actually blocks the production of estrogen completely, so you're estrogen zero. Ovarian suppression, which is when we give drugs, things like Prostat, injections to shut the ovaries down. And the reason we do these, all three treatments, are because not most, but a lot of times the breast cancer is estrogen positive. So we have ER positive, we have ER negative. There are other receptors too. There's progesterone receptors, and there's HER2 receptors as well. But the one that we're most concerned about in terms of recurrence is the estrogen receptor. And this is why we target these treatments to prevent the recurrence being triggered by estrogen. Next slide. So, you would have discussed these therapies with your oncologist, and oncologists are brilliant at what they do. And like I was saying before, the survival rates for breast cancer today are amazing. And one of the reasons they're amazing is because of these endocrine therapies. And when you discuss these with your oncologist, they're very focused on what your risks are and how they can reduce your risks. But what we're not seeing consistently is this. We're not seeing
why you like camping. I cannot understand how you like camping.
The side effects of endocrine therapy. So, I've spoken to many women now who have gone through breast cancer, who have spoken to their oncologist, and it's stark. So many of them have never had the M word mentioned. They've not been told that they're going to go through a menopause. They've not been told about the side effects of the endocrine therapy. So basically what Farah was talking about, it's all the same side effects that we're seeing in breast cancer, but there are a few side effects that seem to be more stark in these women who go through endocrine therapy. So the hot flushes and the night sweats, these can be really intense. Joint pains and muscle pains, probably one of the most common symptoms, probably the most common symptom I hear about for women who are on aromatase inhibitors. And the reason this is so important is because of what Farah was talking about, how when we go through menopause, we know that the hormone reduction is causing an increased risk of cardiovascular disease. It's leading to a reduction in bone density. And when these women are going through these symptoms like joint pains and muscle pains, the last thing they want to do is exercise. The last thing they want to do is do their 30 minutes 3 times a week. And it's for that reason that we need to be thinking about how do we treat this symptom. Vaginal dryness, where do I start? This is, again, probably one of the worst symptoms that women go through after breast cancer. And within our community, it's the least talked about symptom. We just don't talk about this. It's not mentioned. It's not just vaginal dryness. It's painful intercourse. It's urinary discomfort. It's increased frequency. It's accidents. And then it's reduced libido. This has a knock-on effect on our sex drive, intimacy, relationships. And it's just, unfortunately, this is brushed under the carpet, but it's a real part of our daily lives that needs to be addressed. And then lastly, bone density loss. Again, this might not be something we see immediately, but it's more stark. So Farah talked about the loss of bone density that we experience as we go through menopause. This is doubly so with the aromatase inhibitors, especially because we're blocking that estrogen completely. We don't even have that background estrogen running that we do when we go through a natural menopause. So we know that these women are going to lose more bone density. And again, that comes back around to what Farah was talking about how we need to be lifting heavy, we need to be exercising. If there's no impact on these bones are going to lose density really, really fast. So impact exercise, how can we get these women to exercise? So that's what we're on a mission to talk about today. Next slide, please. Okay, so just emphasizing this that I'm really passionate about is genitourinary syndrome of the menopause, this is real, and this is what our women who've had breast cancer are really struggling with. They might not be talking about it, they might not be telling you if you're their sister, their friend, but this is happening to them. Painful sex, they're probably not even having sex because it's so painful. Vulvovaginal pain, you know, women who can't even wipe themselves with toilet paper because they bleed. You know, that's the level of discomfort that they're experiencing. They can't sit comfortably. Everything is painful. Urinary urgency, frequency, leaking. So urinary symptoms can be really disabling. You know, you're going out, making sure you're toilet mapping, so you're not able to go out unless you know where the nearest toilet is. And that can be really, really frustrating. Diminished or absent orgasm. So for women who are still, you know, intimate with their partner or husband, it's that, you know, that lack, things aren't the same anymore. Difficulty reaching orgasm, difficulty in, you know, painful penetration, and just overall dryness and pain can be a real issue. Next slide. So what I want to touch on, and again, I'm not an oncologist, but this is really important that we do discuss with our oncology colleagues. And when you know, if you are to see your GP or if you were to see a menopause specialist like me or Farah, what we would do is we would discuss this with your oncologist, because every breast cancer is different and the recurrence risk for every breast cancer varies by tumor type, stage, treatment. And one of the tools that we use is called the PREDICT tool, and that estimates your risk of recurrence. And it might be that your oncologist has discussed this tool with you and told you that, right, if we go on an aromatase inhibitor, we're going to reduce your risk of recurrence by, you know, 5%. If we go on tamoxifen, it's going to be a reduction of 2%, or whatever those risks are. It's really important to understand what your recurrence risk is and why they're putting you on these treatments. And it's really important to have a personalized discussion, because it's very different for different people. And the reason I say this is because sometimes women are just made to feel like they don't have a choice, that they have to go on these treatments. And it's really sad. I've spoken to some women who've told me that they've stopped taking their aromatase inhibitors. They can't handle the symptoms, so they're religiously going to the pharmacy and they're picking up their prescription every month, but they can't bring themselves to tell their oncologist they're not actually taking it because they can't handle the side effects. And this is why we need to be having these really stark conversations, because there are other options, and there are other options that maybe will reduce the risk an equal amount. It may be a difference of 1 or 2%. And this can be really important and I'll talk a bit more about this, about vaginal estrogen later on, because vaginal estrogen can be a game changer when it comes to genitourinary syndrome in the menopause. Unfortunately, most doctors are of the opinion that we can't give vaginal estrogen if a woman is on an aromatase inhibitor, but it is absolutely safe to use if they're on tamoxifen, or if they finish their endocrine treatment completely. So it could be a case of, right, I'm going to discuss my risk with my oncologist. Maybe, and just maybe, you could switch from your aromatase inhibitor to tamoxifen, which would then enable you to start a vaginal estrogen, and that could make all the difference. Next slide, please. So the tool that they will use is the PREDICT tool. And it's a really simple tool. You can actually access it online yourself, and it incorporates your tumor size, the grade of your cancer, lymph node involvement, your receptor status, and your age. And then what it does, it will tell you the benefit, the estimated benefit of all the different treatments, of all the different therapies. And like I said, you know, switching between therapies may well make the difference to your symptoms. And it's always a shared decision making between the patient and their clinician. So you should never feel like this decision is made for you. You are very much a part of it. And every woman will have different risk appetites. Some women will want to be on the treatment that reduces their risk the most. Other women are happy to take, you know, a 1% or a 2% less beneficial treatment if it means that their symptoms are better controlled. And they want, you know, quality of life is obviously very, very important. Next slide, please. So still carrying on about genitourinary syndrome and the menopause, this is such an important area, I feel, so I'm spending a bit more time on it. The first line is non-hormonal treatments. So before we even talk about estrogen, this is something we always say, go away and try. It's, you know, it's very, very safe. So first thing would be vaginal moisturizers. And the key here is to make sure you're getting one of the ones that are pH balanced, that don't have perfumes, that aren't irritants to that vaginal mucosa, which is already very dry and very irritated. So the ones that we would probably recommend is, so I really like Yes, and you can see a picture of Yes at the bottom there. All of their products are pH balanced and non-perfumed and are very, very good. Replens is another one. And there are quite a few out there, but they have to be tailored to the vagina and vaginal pH. Then lubricants. So lubricants are for increasing comfort and reducing friction during sex. So this is really important that, you know, when we're thinking about intimacy and we're approaching intimacy, we are thinking about how can I make this a more comfortable experience. And, you know, I'm very aware that there are many women out there who are just thinking in their heads, I can't even think about sex. You know, this is a subject I don't even want to go in it because they're so scared. There are also women that I speak to who want that intimacy back, who are very aware that this is something that is causing problems in their relationship, and they want to build that intimacy back in. So, I mean, my advice would be, this is something that doesn't happen overnight, and this is something that is a journey that you and your husband need to go on together. And there is, you know, I've seen this, I've heard stories that there is lots of hope, there's lots you can do, but it's very much a stepwise process. You know, I spoke to a woman the other day, and she said, you know, I'm scared to even hug my husband because I'm worried that's the green light that, you know, we're going to go all the way. But it's really interesting. What's not happening is those conversations, because he's also probably feeling really scared. He also doesn't want to cause you any pain, and he's also probably missing the intimacy. So it's something that needs you know, an approach between the husband and wife. And I'd really recommend psychosexual counselling, because that stepwise approach and that understanding between the husband and wife can be facilitated through counselling. I'm just going to touch on some other things. So self-stimulators, vibrators, they have a place, and you know, I'm not a scholar in the religion, so I don't know if there's a ruling on this, but this can be something that's a joint thing between the husband and wife. So we know that stimulation can facilitate natural lubrication, maintain sexual function. So whether that's a vibrator or you know, other sexual toys, there is a place for them, and they can really, really help as one of the steps in, you know, getting that intimacy back. And like I said, it doesn't have to be a you thing, it can be a couple thing. Dilators, and you can see the range on that picture there, they come in lots of different sizes, and these are really good for helping with pelvic pain, vaginal pain. So one of the things I see a lot is hypersensitivity, you know, vaginal spasm, and using dilators, you can, and I think the word dilator is a bit misleading because it's not actually dilating anything. It's just going in and getting your pelvic floor used to having that dilator there, and it teaches you how to relax the muscles of your pelvis again. And again, this is one of the really important steps towards intimacy, just being comfortable and relaxed. So yeah, I mean, food for thought, but completely appreciate this is such a heavy topic for many women and men, but there is help out there. And one of the things I would strongly recommend is listening to the Menopause and Cancer podcast. There's some really, really good talks on this, approaches you can take, help that's out there. And I'm wondering if Neva might touch on that later as well. Next slide, please. So what about vaginal estrogen? So you've tried the moisturizers, you're using your lubes, things are still really uncomfortable. So low dose vaginal estrogen is a safe treatment in women who have already tried moisturizers and are still struggling with their symptoms. They're safe for women who have finished their endocrine treatments. They're also safe for women who are taking tamoxifen. The jury's still out on aromatase inhibitors, and most oncologists will err on the side of caution and not prescribe it because, like I was saying earlier, the role of an aromatase inhibitor is actually to have zero estrogen. There are some very low dose vaginal estrogen products, things like Blissol, Invagis have a very small amount, so those would be the ones that I would normally start in my patients. For women who are on an aromatase inhibitor and they are struggling, one of the options that I have seen is something called DHEA, and it's a vaginal pessary, and it converts to estrogen, but it only converts to estrogen and testosterone within the epithelia of the vagina. So all the studies that we're seeing now seem to show, and again, we don't have enough data, but the data that we have does suggest that there's really no absorption into the bloodstream, and that's one of the ones that I think if you are on an aromatase inhibitor, your oncologist may well be happy with you starting. So don't forget that if you're on a aromatase inhibitor, you might well be able to switch to tamoxifen, and then you can take a vaginal estrogen. The other thing is you can have a holiday. So some women actually ask for a holiday from their aromatase inhibitor, and that's a real option. Next slide. So what about the other symptoms that we're talking about? So non-hormonal treatment options, there are a few things out there. And I kind of see some of these treatments a bit like sweets in a sweet shop that, you sometimes need to mix and match, try a few different ones before you find the right sweet for you. Literally find your sweet spot. So the problem with these is often the side effects that we see. So one of the ones that we will try, and this is not just for depression, is an antidepressant because it can work really well for hot flushes. And I tend to group symptoms when I talk about which treatment is best for you. So the reason I would probably suggest an antidepressant in a really low dose first would be if you had both the hot flushes and the low mood. So low mood, anxiety, and hot flushes would be a good combination to think about starting what we call an SSRI or an SNRI. If you're on tamoxifen, there are SSRIs that you're not allowed to use, such as paroxetine and fluoxetine. So we'd probably start you on venlafaxine, which is an SNRI. If you're on any of the others, then it's fine, and escitalopram is usually my treatment of choice, which seems to work quite well at quite a low dose. If your symptoms are more joint pains, the neuropathic painkillers, gabapentin and pregabalin, again in a very low dose, can work quite well, and that will also help with hot flushes. So that tends to be my treatment of choice if the joint pains and the hot flushes are both present. Oxybutynin can also work. So oxybutynin is a treatment that we use for urinary incontinence, for overactive bladder, but we've since realized that it actually does really help with hot flushes as well. So it's one of the ones now that we prescribe in women post breast cancer for urinary symptoms and hot flushes because it seems to help with both. I quite like this one because it's available as a patch, so it almost feels like you're using a HRT patch every day, which can normalize it a little bit. Again, the main side effect from this can be dry mouth that we see quite often. So it doesn't suit everyone, but it can be really helpful for some. The next one on the list is a medication called fezolinetant, which I'm just going to touch on because I think this is a bit of a game changer. It works on our NKD receptors in our brain, which are responsible for thermoregulation. And by inhibiting these receptors, we've seen that we can actually switch off these hot flushes. And what's really exciting is this is a non-hormonal treatment that seems to be very effective for hot flushes. So historically, there hasn't been much data on breast cancer and fezolinetant, so we've been a bit hesitant to prescribe it. There is a new trial called the OASIS trial, which is now undergoing their 4th phase, and there is really positive data coming out in these women with breast cancer that it's safe for breast cancer, it's effective for hot flushes, and it's also it significantly improves their sleep as well, which is the other symptom that can be really difficult in the menopause. And then there's vagina moisturizers and lubes that I talked about. CBT can be really helpful, cognitive behavior therapy, not just for psychological symptoms, but CBT for hot flushes and insomnia as well. And then the lifestyle adjustments, which Farah talked about, really important to get these going because they can make a significant difference on our symptoms. Next slide. And lastly, I just wanted to touch on supplements because me and Farah always get asked about supplements, don't we? I think for me, I will always say that, supplements, I'm not an expert in herbal preparations, and I would always exercise caution, especially with breast cancer. So vitamin D, calcium, I think Farah talked about that. Those are, very safe and essential for bone health. There is some evidence for omega-3 fatty acids for joint and mood support. So those are good ones. Also for the risk of cardiovascular disease. So that's quite a good one to maybe start. Black cohosh can be useful for hot flushes, but again, just, think about side effects. There are possible side effects on the liver that we need to be aware of. Evening primrose oil, limited evidence, but can be helpful. And then just be really careful about phytoestrogens, things like red clover, soya, isoflavones. They are natural phytoestrogens which can trigger your estrogen receptors. So always best to discuss with your oncology team to see if you're allowed to use them. And that's it, I think. Oh, so last slide. We talked a bit about HRT, and most women would have probably been told that because you've got a hormone dependent cancer, that HRT is off the table. What NICE actually say is that in women with a history of breast cancer, in exceptional circumstances, they can try HRT. And this is usually when we've tried other things and we're not successful. If quality of life is really impacted, this is something that there are women out there who've had breast cancer who choose to go on HRT. We know that HRT is the most effective method of symptom relief, and actually we don't have great data, and this is the thing. This is why actually it's a really difficult decision. We have 2 observational studies. Both of them were tiny, so there were only like 200-300 people in each study, which isn't a statistically significant, large randomized trial. And both studies were conflicting. So the Habits trial did show a small increase in breast cancer recurrence, whereas the Stockholm trial showed there wasn't an increased risk in breast cancer in women using HRT. Both of those trials were stopped early, and like I said, there were really small numbers. So it's really hard, but theoretically there is an increased risk of recurrence, and it's really down to that, looking at your personal circumstances, understanding what your risks and your benefits would be, putting it into your lifestyle and your quality of life discussion, and then deciding if it's right for you. So yeah, it's not off the table, but we always would get oncology input before starting you on it. And I think that's it now. Yes.
Thank you so much, Sisters Farah and Farad. We've got a few questions that have come from the chat box. First one is from Hina. I wanted to ask about thyroid cancer and if there are similarities with breast cancer in regards to the menopause symptoms. Dr. Furrett?
So I think it depends on what treatments you were given. So if you've had chemotherapy, we know that that can give you an early menopause. I mean, as far as I know, Farah, correct me, there is an overlap, yes, because we know that thyroid deficiency can cause some of the symptoms like low mood. It can cause temperature dysregulation. Normally, cold, yeah, you get sort of a lower end of the temperature range, but I don't necessarily see hot flushes, so it's slightly different. There is overlap, but from my perspective, I think it's quite a different symptom profile.
Thank you. The next question, I think may be more appropriate for our scholars, but I'll ask you just in case. The question is, what is available for sisters who are divorced, single, etc.? Something which is considered a halal safe method. Sorry, I didn't know how else to ask.
Yeah, so again, I think, that would be one for the scholars a little bit. I'm not an expert on jurisdiction, but definitely going down the vaginal moisturizers, that's completely acceptable. And dilators aren't just for sex. Dilators are there for pelvic pain, for pelvic floor dysfunction. They can help in different ways. So that's still something to consider. Beyond that, I'm not an expert, but it really depends, I think, a little bit on your intention as well behind it. So yeah, I will leave that one to the scholars.
Thank you. Sister, if you want to email that question over to us at hello@safina.org.uk, we can put that to one of our female scholars and get you a comprehensive response to that. Next question is from Safina. Can pessaries, I don't know if I'm pronouncing that right, be replaced with creams as my doctor has only prescribed pessaries?
Yes, absolutely.
The one thing I would say about pessaries and creams, you can actually have both. So you can use pessaries vaginally internally, but with vaginal cream, the advantage with that is a bit messy, but if you put a blob on a clean finger, you can rub it around the outside, so your labia, your clitoris, your urethra, and that really helps to replenish all the moisture, restore the architecture of the vulva as well, not just the vagina.
Thank you. Next question, I think may not be appropriate because it may be more for an oncologist, but I'll ask it anyway for completeness. The project online says it's not designed for ductal carcinoma. Why is that?
I think, it's more, advanced cancers. But yeah, I'm not 100% sure about that.
Brilliant, thank you. And I'll ask another question from the chat, and then I know that there's a couple of people who've got their hands up, so I'll come to them. The next question is from Shaida. Can I ask about the benefit of having a Mirena coil alongside the HRT patches for someone who may be worried about breast cancer?
So you can take the Mirena coil has lots of advantages. It can be used for heavy menstrual bleeding. It can double up as contraception, as well as the progesterone component of your HRT. So if you remember, HRT is your estrogen and your progesterone. So if you have the Mirena coil in, like I said, it has two roles as the progesterone part of your HRT, but also contraception. So all you really need is additional estrogen on top, so you can take an estrogen patch quite safely with your Mirena coil.
Thank you. You've got your hands up. Do you want to ask your question? I don't know if you're on mute.
Yes,
Margaret, sorry. I could only see the
Oh.
I'm afraid. Sorry about that.
Hi, can you hear me?
Yep, we can hear you.
I work in breast oncology and prostate oncology. So I'm an oncology specialty doctor. And the PREDICT is for early invasive cancer, but not for ductal carcinoma in situ.
That's helpful.
Yeah.
Thank you, Margaret. and ZW. Sorry, I can't see the full name.
Zainab?
Zainab, thank you.
Yes, I just spoke about the ductal carcinoma in situ. That wasn't Margaret. That was me.
Oh, okay, brilliant. Thank you. And Margaret, do you still have a question that you wanted to ask?
So I have a question. I would like the slides for this session. Is it possible for you to send it to me?
We can just take that away, and if we're able to send the slides, we can send it to the attendees. The other thing that you can do, of course, is that the YouTube recording will be available on our YouTube channel in a couple of weeks, in a fortnight's time. It'll be uploaded and the slides will be there as part of the recording.
So the
So you'll be able
YouTube
to
channel,
view
okay,
it.
I just have to go to YouTube and type
Yeah.
Safina.
Yeah, I think it's called Safina Muslim Cancer Support Network YouTube channel. If you type that in to Google, it will take you to the site.
Safina Muslim and Cancer Network website.
Cancer Support Network.
Cancer support website. Cancer support website.
Yeah.
There's a Q&A service, free service for medical. Is this online? Is this in your
On our website?
Yeah. What about the cookbook for foods? Is this in your website as well?
Yeah, the online version, the e-version is available now on our website, and you can download that for free. But if you would like a hard copy, then just email us at hello@safina.org.uk.
So this is
our email address, and then we'll arrange for a copy to be sent to you as soon as it comes from print.
So it's online, but I can email you to get a hard copy.
Yes.
Also, and that, the GSCM, what does this stand for? Just GSM.
Yeah,
What is
that's
that?
for genital urinary syndrome of the menopause. So things like vaginal dryness.
Sorry, what does it stand for? Syndrome. Sorry.
Yeah, it's a long one. I'll put it in the. Oh no, I don't know. I don't think I can use the chat. Oh,
syndrome.
Yes, I can. I'll put it in the chat, and then you can see genital urinary syndrome and of menopause. Oops. There you go.
Thank you so much. Next question is someone who is 55 and who has not removed the Mirena caul that was inserted for over 10 years tends to have irregular bleeding and is concerned that she may not be menopausal yet. She is of black background and not based in the UK. Any advice for her, please?
That coil needs to come out. It's been in there far too long. But she can have, she probably is menopausal being 55, but we can do an FSH blood test, which, to be honest, if she was in the UK, we wouldn't do in a woman that's over 55, because if they're having symptoms, it's safe to presume they're probably perimenopausal. But essentially, the coil has been in for far too long, and that needs to come out, and then see what happens to the cycle after that.
Yeah, I think, if she's concerned, it probably would be worth seeing her GP and getting a scan as well. But completely agree that 10 years is too long. You don't want it to be embedded, or you don't want it to migrate. There is the option, if she wants HRT, to have it replaced for the use of HRT, but she wouldn't need it for contraception after the age of 55.
Thank you. Noreen, I think you've got your hand up. Would you like to come in?
Assalamu alaikum.
Alaikum.
Jazakallah khair to everybody who participated in this and made me part of this. A question for maybe Sister Zahida. So you mentioned something about volunteers at the beginning and how you have volunteers. Is there some kind of training for these volunteers before they can do anything to start volunteering, basically? Just wanted to ask you that question.
Yeah, so we have two main type of volunteers for Safina. One's the befrienders and the other are community cancer champions, and both of them have a comprehensive training program that they have to undertake before they can volunteer, and that's been developed with consultation with a number of leading charities dealing with befriending support service, and that's available. That can be done online, or it can be done in person as well.
Oh, okay, great. Thank you.
Thank you. I think that's all the questions that we have. I just wanted to say thank you so much to Dr. Farah and Dr. Farah for a really comprehensive session today on menopause. And hopefully it will have increased people's sort of education and awareness around this topic, but also started the conversations around cancer. And I'm really pleased to see some male brothers joining the session today. And I think it's really important what Dr. Farah said as well. Males perform a very important role and are important allies in this journey as well. So it's really important that they understand about the symptoms of menopause, both during treatment of cancer, but also through a natural menopause as well. So thank you so much, sisters, for taking part in this session. And I just wanted to end this session with a short dua, which is that, Ya Allah, please place blessings and rewards for everyone who contributed, who attended, who organised or supported in any way, especially Sisters Farah and Farad, and everyone at Safina, particularly Nadia and Amina. And please grant us sincerity and accept our efforts and allow the good to continue beyond this gathering. Ameen. Thank you once again, everyone, for attending. Hope you found the session useful. If anyone has any comments, feedback, please do get in touch with us. And if you want us to do anything different, please again get in touch with us. We very much take on board the views from the community that we serve, inshallah. Thank you so much once again. Assalamu alaikum.